Dear professors, dear colleagues, dear friends, we are more than happy you joined us on this autumn Sunday afternoon, evening, maybe night in some countries. We have an extended international audience of mental health professionals who follow this important educational initiative, supervised by Professor Konstantinos Fontolakis, who is the head of the Department of Psychiatry in the Aristotle University of Thessaloniki, and also the WPA Zone 8 Southern Europe representative, director of Cochrane Greece, and World Health Organization representative for Greece since 2021. Today's event is coordinated by the Master of Sciences program on clinical mental health of the Aristotle University of Thessaloniki, and within the action plan 2020-2023 of the World Psychiatric Association Working Group on the Evidence-Based Psychopharmacology. This event is also organized in collaboration with the International Center for Education and Research in Neuropsychiatry, Samara State Medical University, and the Department of Psychiatry of Riga Stradiņš University. I would like to say hi to my dear co-moderator, Associate Professor Elena Rublevska from Riga Stradiņš University. Hello.
Hello, dear Daria.
And you remember the first Meet the Expert session, which took place several months ago. And sure, you remember our great speakers, Professor Sir Robin Murray from the United Kingdom and his talk on schizophrenia, and Professor Siegfried Kasper from Austria, who was talking about depression. But first of all, before we introduce two exciting talks from our prominent speakers today, I would like to invite Professor Afzal Javed, who is, everyone knows, acts as the president of the World Psychiatric Association. Professor Afzal Javed is a honorary clinical associate teacher in the Warwick Medical School, University of Warwick, UK, and the chair of Pakistan Psychiatric Research Center in Lahore, Pakistan. And we would like to express our sincere gratitude to Professor Afzal Javed for his incredible continuous support of all the educational and scientific activities of the international collaborative groups of mental health professionals. And during this difficult time of pandemic, we would like to have this series of important professional events and webinars in 2020 and 2021 under the auspices of the World Psychiatric Association. Dear Professor Afzal Javed, we would be very happy if you share your welcome message with us. Thank you.
Thank you very much, Daria. And thanks to the organizers, especially Professor Fontolakis, who is our zonal representative as well as the chair of our WPA section on psychopharmacology. I think this master's course is an excellent contribution to the science and, more importantly, to the continued professional development that is very important all over the globe. I'm really glad that the organizers have started out a series of webinars that are attended by a number of people from many countries around the globe. But more importantly, very high caliber experts who have very kindly accepted to be the guest speakers. This is indeed a combination of science, a combination of clinical expertise, and more importantly, a direction for our postgraduate and other students to get wisdom and expertise from our very, very renowned and esteemed lecturers. I'm really pleased that today we have got another two very important speakers, and I do not want to stay between the audience and the speakers. So with these words, please accept the greetings and best wishes from World Psychiatric Association. And we are grateful to the organizers and the two speakers for their kind support and help to this program. Thank you very much. Over to you, Daria.
Thank you very much, dear Professor Afzal Javed. Thank you for your greetings, for your incredible support. And now we are glad to introduce our lecturers. The first speaker will be Professor Heinz Grunze. Professor Heinz Grunze has got his qualification in medicine from the University of Aachen, Germany, took up research fellowships of the prestigious Max Planck Institute of Psychiatry working in Freiburg, Germany, and later with the DFG stipend at the Department of Psychiatry in Harvard Medical School in Boston, United States. After a period as senior registrar at the Department of Psychiatry, University Clinic Freiburg, Professor Grunze took up an appointment as a consultant and lecturer in psychiatry in the Department of Psychiatry, Ludwig Maximilians University, Munich, Germany. From 2007 until 2015, Professor Heinz Grunze has served as Professor of Clinical Psychiatry at the Institute of Neuroscience at Newcastle University in the United Kingdom. And in April 2015, he was appointed as a Professor of Psychiatry at the Paracelsus Medical University in Salzburg and the head of the University Department of Psychiatry. Since 2017, he serves as the head of the Department of General Psychiatry in Germany, while he continues his academic affiliation with the Paracelsus Medical University. Professor Heinz Grunze has received several grants from national and international institutions, including a Stanley Foundation International Center Award for Clinical Studies in Bipolar Disorder. He is a member of several national and international neuroscience and psychopharmacology associations and serves as a secretary for the World Federation of Societies of Biological Psychiatry within the Bipolar Disorder Task Force. Professor Grunze is the member of the editorial boards of the list of peer-reviewed journals, including the Annals of General Psychiatry, the International Journal of Bipolar Disorders, and others. And over his very successful academic career, Professor Grunze has published numerous original research articles, reviews, books, and book chapters on his main research interest, the neurobiology and treatment of bipolar disorder, depression, and addiction. According to the Scopus database, Professor Grunze has published more than 320 peer-reviewed papers with a total number of citations exceeding 14,000. Professor Heinz Grunze has published the most cited recommendations in psychopharmacology, working with the task force of the International Society of Bipolar Disorders on antidepressant use, the evidence-based guidelines for treatment of bipolar disorder from British Association for Psychopharmacology and the World Federation of Societies of Biological Psychiatry guidelines for biological treatment of unipolar depressive disorders, and many other important documents in the field of the evidence-based psychopharmacology and their regular updates. Among awards of Professor Heinz Grunze is the 2015 World Journal of Biological Psychiatry Excellence in Publication Prize, received from the hands of Professor Siegfried Kasper. Prof. Heinz Grunze has nominated for his outstanding input to the scientific impact of the journal 4 of his treatment guidelines of bipolar disorder by World Federation of Societies of Bipolar associations are among the top 10 of the journals most cited at all time. Once again, it's my pleasure and honor now to welcome our respectful Professor Heinz Grunze to the floor of our midday expert session. The floor is yours, Prof. Kroenzer.
Well, thank you, Daria, for this nice introduction, and thank you, Kostas, for inviting me to this, I think, excellent series of webinars which you have designed. Well, first I have to apologize for chaos in my back. I'm just sitting here in Germany in my private room, in my private office, not in my official office in the hospital. And as you see, I'm just not really good in just keeping things in good order. So please apologize for the background. Yeah, my topic today is a quite controversial topic. And when Kostas basically assembled a lot of experts to compile the CINP guidelines for bipolar disorder, they actually found that there is much more controversy and much more opinion probably than evidence in some specific areas. And about one specific area, I'm just going to talk today. And let's see whether this works here, whether you just can see those slides and whether this is working. Is it? Did it? Okay. Quick feedback. Daria, slides are on. You can see them.
Yes, we can.
Okay,
Perfect.
great. So ready to start now. Well, this is the area really on controversy. As well, better say, the first part of the topic: are antidepressants mood destabilizers? Disorder. Please be aware about my conflicts of interest, which are shown on this slide here. And let's go right into the topic itself. Well, why is it quite important to think about bipolar depression, probably more than thinking about mania? The reason is depicted here. This is actually data from the Stanley Foundation Bipolar Network, where we actually were working or part of this network from 1998 to 2002, collecting naturalistic data of, at the end, more than 3,000 bipolar patients. And looking into the different episodes and phases of the illness, Ralph Kupka actually published these data in 2007. This is prospective follow-up of bipolar 1 and bipolar 2 patients over 1 year with daily mood charting. And what you see is that probably half of the years is actually the green part of this diagram. Patients are reasonably well. I wouldn't say absolutely well, but at least they're not an acute episode. The other half of the year, they're either in the manic, depressed, or mixed episode. And if you see the distribution between depressed time in depression and time with mania or hypomania in the case of bipolar 2, you see that threefold the time they are depressed and they're manic, and probably 1/3 of the whole year they actually suffer from depression. So I think that really makes depression more the hallmarks in bipolar disorder than probably mania does. Also being aware about all the consequences of depression, starting from functional disability until suicide. So I think it's very important just to have a closer look into optimal treatment of bipolar depression. But unfortunately, most energy of the pharmaceutical companies was concentrating on mania over the last decades. So data are relatively sparse compared to what we actually have in mania. The other thing I just want to mention is if you talk about bipolar depression, you not just talk about patients who are just purely depressed. And this is important if you talk about antidepressants. Only about 1/3 of the patients with a diagnosis of bipolar depression have no manic symptoms at the same time, meaning that 2/3 have either subsyndromal manic symptoms, that means 1 to 3 manic symptoms while they're depressed, or might even fulfill the old DSM-4 criteria for a mixed episode. So depression without any manic symptoms is rather the exception than the rule in bipolar depression, and puts clearly patients on risk of a switch into a full-blown manic episode. Now, how to treat best bipolar depression? And if you talk about treating depression, you automatically think about antidepressants, clearly. So what do we know about antidepressants in bipolar disorder? First, we know that they're used quite frequently. These are data from Denmark from 2015, looking into the treatment habit of Danish doctors in the period 1995 to 2012. And you see tendencies for different medications. For example, lithium is a green one, which is almost stable, little decline towards the last years. You see actually the atypical antipsychotics with a strong rise between 1995 and 2012. At the same time, with a decline, it's the black line of the typical antipsychotics, and also with a rise of the anticonvulsants, probably mostly due to lamotrigine entering the market. But what you also see is the blue line just on the top. The most frequently prescribed medication for bipolar disorder in Denmark are antidepressants. And if you look a bit more into detail, you actually see that most of these antidepressants, the majority are SSRIs. There are also some contribution of NSAIDs and SNRIs, whereas tricyclics are actually quite on the decline since 1995. So a frequent use in Europe. What about the other side of the Atlantic Ocean? These are data of the STEP-BD study, looking at baseline into the treatment habits and into the medication of patients entering these large network. And what you see actually on the left-hand side of the slide is the distribution between the different groups, mood stabilizers, new mood stabilizers, which is mainly lamotrigine, then actually mood stabilizer monotherapy, next the second generation antipsychotics, benzodiazepines, and finally on the right side, the antidepressants. And you see also in the US, 40% of bipolar patients are on antidepressants. And they're not just on antidepressants while depressed. If you look at the right hand of the slide, while they're depressed, 46% of patients receive antidepressants, but they still do have a fair contribution while they're euthymic, about 40%, and even during hypomania or mixed state, there are still antidepressants actually on the agenda, about 32%. So the question is, are all these doctors crazy? Are they not aware about the risks of switching into mania and what antidepressants can cause in bipolar disorder? At least if you believe the older publications on that, or is there any real good reason to use them? Are they probably also efficacious? And this are some meta-analyses really asking about the efficacy and also later on the switch risk of antidepressants in bipolar depression. This is the oldest one from 2004, actually only having 4 studies included into this meta-analysis, where you see here about half of the patients, or even more than half of the patients, are just from one study, which is the TONE study, looking into olanzapine fluoxetine combination and placebo in bipolar depression. And what you see with these studies, mainly conducted either in fluoxetine or in MAO inhibitors, shows, if you look at the black diamond on the right-hand side of the line of equivalence, that antidepressants as a group are effective in treating bipolar depression in this meta-analysis, which actually is still including little trials because little evidence available at that time. Now, a later meta-analysis by Sealer and McQueen, published in 2011, actually included 5 studies and comes to a slightly different result. So you see here, this gray diamond on the bottom of this meta-analysis just touches the line of equivalence. So there is a signal, or there is a tendency for antidepressants to be effective, but it's just missing significance. Now, you may notice that the trials included in this meta-analysis are not identical with the one before. And that's really one of the problems which we have as time goes on and time goes by. We got more studies, we got other criteria for quality of including trials, and as a result, we got different results for meta-analyses. The next one, 2 years later, from Vasquez, now again shows actually a clear signal, a significant signal in favor of antidepressants, the black diamonds on the top, and now including not 4 or 5, but as you see altogether 10 studies. So obviously other criteria of selection. The interesting thing is on the right-hand side of the slide, they actually compared the numbers needed to treat for a response in this meta-analysis, which antidepressant bipolar disorder, with actually a meta-analysis in unipolar depression. And what you see actually is that the numbers needed to treat for bipolar is 6.2, and for unipolar, including more studies, clearly there are more studies available, is 8. So this suggests that antidepressants, if it comes just to treating depressive symptoms, are as effective in bipolar depression as they are in unipolar depression, at least as effective. Another analysis by Tondo and colleagues actually also strengthens the signal and shows the same result, comparing actually percentages of patients remitting in unipolar depression, bipolar 1 and bipolar 2 over time. And you see after 24 weeks, there is no difference in the results in remission on antidepressants across the affective spectrum. Now, finally, what is considered as probably the best evidence are network meta-analyses, where you not only have one study comparing your drug against placebo, but where you compare between different comparators. And what this meta-analysis by Taylor found is that actually olanzapine and fluoxetine are probably the most effective treatment for bipolar depression. Now, if you actually think of a specific study where this combination was tested, it was pretty clear that only the addition of fluoxetine was a real success. Olanzapine itself had only a moderate influence on depression. I will get to this one later during my talk. And they also showed that there are some efficacy of SSRIs and tricyclics, also including older studies. So this was acute treatment. What do we know about bipolar maintenance? Because what we want to achieve at the end is that we do not have to treat acute bipolar depression because we can prevent it effectively. So is a place actually for antidepressants and long-term treatment of bipolar disorder. This is a quite recent meta-analysis by Leo from 2017. I hope you just can see it on the screen. It's rather small. If you actually, you see the different studies on the left-hand side, comparing first, that's the small a, antidepressants versus placebo in depression, in preventing new depressed episodes. Then actually antidepressants versus placebo in preventing new manic or hypomanic episodes. Then C, antidepressants versus mood stabilizers for preventing depression, and the same again for preventing mania and hypomania. And I don't know whether it's going to be visible on screen. If you look here for bipolar 1 and 2, you actually see a signal, a significant signal for bipolar 2, antidepressants versus placebo in preventing new depression. It just misses significance for bipolar 1. For combined bipolar 1 and 2, again, it's significant. And it seems that actually efficacy gets better over time. This is for 6 to 24 months after the index episode. And this, this is for the long term, and this is for the short term. So short-term continuation therapy more effective, probably slightly more effective than in the long run. What we see here is the prevention of mania or hypomania. And you would actually expect if antidepressants induce mania, you have a clear signal favoring placebo, but you don't have it really. If you look into bipolar 1s and bipolar 2s, there is no significant difference between these two signals, also not for the combined one. There's a tendency for placebo better being in preventing manic and hypomanic, or better saying not inducing manic or hypomanic episodes. And in the short term, it looks even for like a tendency that antidepressants might be more preventive against hypomanic or manic episodes, but not in the long run. Compared to mood stabilizers, first generation mood stabilizers, so basically lithium, valproate, mood stabilizers, first generation antidepressants, tricyclics, preventing new depression, no difference to mood stabilizers. And second generation antidepressants, so the modern ones, seems to be even slightly better in preventing a new depressed episode. Whereas if you look into mania, we see actually a signal for first generation antidepressants, so many tricyclings, rather inducing or being worse in preventing mania than mood stabilizers. We don't see this actually the same thing with the second generation antidepressants. So there seems to be at least a favorable effect of antidepressants for preventing new depressed episodes, and there's at least no overwhelming effect on inducing mania compared to mood stabilizers or placebo. What are actually the results from the STEP-BD study, which was probably the longest study, where actually patients were followed up for a long time period, up to 3 years. This is not actually, as most of these studies, antidepressant monotherapy, but it's also just in combination with mood stabilizer treatment. And they actually had 70 patients included of bipolar 1, most of them actually non-rapid cycling with an acute major affective episode. They responded acutely to treatment with antidepressants and were euthymic for at least 2 months, so were stable or reasonably stable when included, and had an open random assignment either to antidepressant continuation or discontinuation following up to 3 years. And what we see here in those who continued antidepressants compared to those who discontinued antidepressants is, if you look at the first weeks to first depressive episode, 41 weeks in those who continued versus 31 weeks in those who discontinued, which is a significant finding. So in the whole group of the patients, depressed episodes were, or patients were protected against new depressed episodes more when they just continued on antidepressants. When it comes to the first week to first manic episode, interestingly, there's no significant difference between those who continued or discontinued the antidepressant treatment. Of antidepressant continuation. And dividing the group into rapid cyclers and non-rapid cyclers, you actually see looking at the number of new major depressive episodes within 1 year, those rapid cyclers who continued on antidepressant had an average of 1.29 new episodes over 12 months. Those who stopped antidepressant only 0.82. And the opposite is true for those who are non-rapid cyclers. If you're a non-rapid cycler, you had an average of 0.42 new depressed episodes over 1 year. If you discontinued your antidepressant after acute treatment, it was 0.7. So quite obvious from these data, if you're a non-rapid cycler, you have a profit of continuing antidepressants on average. There are more individual factors, which we'll talk about later. If you're a rapid cycler, you're better off if you stop antidepressants after acute treatment. So let's talk a bit more about the risk of antidepressant treatment. And the most common worry is really the switch risk. There had been a lot of publications, mostly case series or single cases in the 70s and 80s, which actually suggested that antidepressants may cause a massive, really, increase of manic episodes and induce rapid cycling. You have to keep in mind the antidepressant treatment at this time was not SSRIs, but was basically tricyclics. So this is basically the historic arguments against the antidepressants in the treatment of bipolar disorder. But if you actually look again into the meta-analyses, which I showed here already, this is the first one, which showed efficacy of antidepressants by Geisman from 2004, with these few studies included in here. You see that there is no difference between placebo and antidepressant when it comes to inducing a manic episode. And the same is also true for the other meta-analysis from 2011, which did not show a significant advantage of antidepressants against placebo, but it also shows no difference when it comes to inducing manic episodes in these patients. Now, comparing actually the risk of getting having a switch into mania or hypomania between bipolar 1 and bipolar 2, it seems that patients actually with bipolar 1 disorder are more on risk than those with bipolar 2. These are the different studies where these analyses of Bond and colleagues looked into. And basically what you see here is favors BD1, favors BD2. So less switches actually happening in BD2 than happening in BD1. So bipolar 1 compared to bipolar 2 seems to be well, bipolar 1 patient seems to be on higher risk to experience a switch into mania or hypomania. This small study by Othmer, published in 2007, also looked into other risk factors for switching into a new manic episode. And common predictors from the literature are either this is an early manifestation of bipolar disorder with a higher risk of switching compared to a late manifestation, a positive family history of mania compared to a negative one, and psychotic symptoms while you are actually depressed compared to no psychotic symptoms. Now, if you're just basically put on risk of switching by inducing or introducing an antidepressant and you have none of these risk factors, your switch risk basically stays pretty low. It's more or less that what we know from placebo treatment and randomized controlled trials. One of these risk factors slightly increases your risk, but as soon as you got 2 additional risk factors in your history, your risk of switching into a manic or hypomanic episode significantly increases when using antidepressants while treating bipolar depression. The other predictor is, and I just would basically go back to the second slide, which I showed you, reminding you that only 1/3 of all bipolar depressed episodes are just pure depression, and 2/3 have more or less manic symptoms at the same time. And what this sub-analysis of Mark Fry, again in the Stanley Foundation patient population showed is, if you basically have a low score, mean young mania score while you are actually depressed, this predicts that you respond to antidepressant treatment. If it's a little bit higher, if you got more manic symptoms or a little manic symptoms while depressed, this can predict a non-response to antidepressants. And if you have actually several manic symptoms or expressed as a higher young mania score while you are depressed here, you actually are on an increased risk of treatment emerging mania. So basically, the often latent and very subtle manic symptoms while you suffer from depression predict whether you are probably on risk of switching into a manic episode. Now, the question is whether it's causative to the antidepressant or just because in general, your illness or your disorder is more unstable and more towards a mixed state than really a pure depression. The other factor, which is probably quite decisive, is which antidepressant you use. These are again data from the Stanley Foundation Bipolar Network. And this was a randomized controlled, but not placebo-controlled study comparing add-on bupropion, sertraline, and venlafaxine to mood stabilizer treatment in acute bipolar depression. And when it comes to efficacy, all 3 medications were quite similar. The difference was really the rate of switching into hypomania or mania. And you see that over the study duration of 80 days, there are only little switches happening with bupropion and sertraline. However, especially towards the end here after day 60, there's quite a lot of patients developing a new hypomanic or manic episode when treated with venlafaxine in bipolar depression. So obviously some noradrenergic input, as you also have if you try cyclics, might make a difference when it comes to switching into the opposite direction. Other risk factors which we know from literature and have been described several times is actually if you have already the history of antidepressant-induced treatment emergent switches, so you're quite likely to switch again. Different comorbidities, especially anxiety disorder and substance use disorder. Female gender puts you on a higher risk of switching. And if you have a special temperament, if you have a hyperthymic temperament, if you actually look into the semi-structured affective temperament interview and you score high with hyperthymia, you're probably also just on an increased risk of developing mania or hypomania with antidepressant treatment. Now, summarizing what we know, and this is obvious not so much, and we should know more about antidepressants in bipolar depression. What we actually see from the different meta-analyses that olanzapine combined with fluoxetine has the highest effect size of all medications. So the fluoxetine, the SSRI in it, is obviously something which is helpful. Switch risk in bipolar 2 is not higher for monotherapy with SSRIs or for SSRIs combined with lithium than for lithium alone. It's actually an analysis by Lori Altschul from 2017, which I didn't show you in these slides. Switch risk is also low in bipolar 1 when you actually combine your antidepressant with an antimanic drug or a mood stabilizer in this widest sense. And the continuation of antidepressants might reduce the risk of depressive relapses, probably without inducing higher rates of mania, except in rapid cycling patients. And clearly in bipolar 1 patients, we really strongly recommend to use a mood stabilizer or antimanic agent at the same time. Now, Daria actually mentioned that I have worked in different task force. One actually was an ISBD task force looking into antidepressants and what we can actually recommend with the use of antidepressants. These are actually those people contributing to it. And the result of this task force and the consensus statements are depicted here. So what these experts said is that adjunctive antidepressants may be used for an acute bipolar 1 or 2 depressive episode when there's a history of previous positive response to antidepressants. Actually, I wouldn't fully agree with that, because what would you do with someone having a first depressive episode? So should you ban him from antidepressants because he didn't have any previous positive response, because he had no previous episode, if he's got severe depression? So I would actually be a bit more cautious with that one. Adjunctive antidepressants should be avoided for an acute bipolar 1 or 2 depressive episode with 2 or more concomitant core manic symptoms in the presence of psychomotor agitation or rapid cycling. I think that's really backed up by the data. Adjunctive treatment with norepinephrine serotonin reuptake inhibitors or tri-tetracycles should be considered only after other antidepressants have been tried. Should be closely monitored because of an increased risk of mood switch or destabilization. This is basically what's also backed up by our Stanley data with venlafaxine. And finally, maintenance treatment of adjunctive antidepressants may be considered if a patient relapses into a depressive episode after stopping antidepressant therapy. So it's obviously a subgroup of bipolar patients who really have a profit of long-term treatment with antidepressants. Now, second part of my talk is about atypical antipsychotics. So if I conclude with the first one, I wouldn't really call antidepressants mood destabilizers. I would actually consider them as quite helpful, however, in selected patients who are not on increased risk of switching into mania. What about atypical antipsychotics? Are they true mood stabilizers or just treating symptoms? Now, the first thing is, if we talk about atypicals, different from mania, we don't talk about the group effect. Not every atypical antipsychotic is, per definition, also an antidepressant in bipolar disorder, whereas basically almost all, at least those tested, atypical antipsychotics work in mania. Now, if you look into olanzapine fluoxetine placebo, you actually see a positive signal significant for olanzapine alone, a better signal, even higher signal for the combination. Whereas for aripiprazole, this study, as you all know, failed at endpoint. There was an initial response, but at endpoint, no difference to placebo. And quetiapine finally has altogether 6 double-blind randomized controlled studies in bipolar 1 and 2 depression, and all look pretty much the same as this one, with quetiapine separating from placebo on a significant level. I mentioned already that I have some doubts about olanzapine as the decisive mechanism in olanzapine fluoxetine combination. And this is due to this sub-analysis by Mauricio Towan, looking into the single items of the MADRS score and how it's actually reacted on the combination of olanzapine fluoxetine compared to placebo and olanzapine by itself. So the red bars is the combination of olanzapine fluoxetine, the black bars is placebo, and the blue bars is actually olanzapine. And if you look in which item you actually pops up here, where olanzapine by itself is superior to placebo, it's very selected. It's inattention here, which you see here, it's reduced sleep and reduced appetite. So all these things we basically think is quite unspecific, and what we all know, no matter what you've got, if you take olanzapine, you sleep better and you have more appetite and your attention probably is reduced, but it's not really depressive core symptoms. It only works on depressive core symptoms like apparent sadness, reported sadness, reduced sleep again here, lassitude, inability to feel, pessimistic thoughts when it is combined with fluoxetine. So this might be actually give some doubt about olanzapine being a real antidepressant besides being an antipsychotic. Now there are others now out which are probably better into this respect, but also at the same time not necessarily an anti-manic agent like lurasidone, where we actually have studies both in monotherapy and as adjunctive design showing an advantage over placebo in treating acute bipolar 1 depression. More lately, we got the addition of cariprazine as a potential treatment of bipolar depression, where actually the dose of 3 milligrams and of 1.5 milligrams separated from placebo in this 8-week double-blind randomized controlled trial in bipolar depression. And most recently, actually, we have lumateperone, which was just published in September 23rd, so brand new published data by Joe Calabrese, which actually shows for this new atypical antipsychotic also advantage over placebo in reducing the MADRS score, in reducing the CGI-BP depression score, and also if it comes to the total responders and total remitters in the MADRS score. So might take some more time before it's going to be available on the market in this indication, but at least the data look quite good at the moment. So summarizing actually what we know about antipsychotics, atypical antipsychotics in bipolar depression, it seems that some of them are quite helpful, especially the newer ones, which have been more recently developed, and quetiapine. Others I would actually raise a little bit of doubt, like olanzapine, whether it really works on core symptoms of depression. If you look into maintenance treatment and preventing new episodes of bipolar disorder, there's a quite very recent, now in press, meta-analysis by Nestyarovich and colleagues, and it actually showed these groups are actually this atypical antipsychotics, which you see here, that they all seems to have effects in preventing new episodes in monotherapy compared to placebo in bipolar disorder. So this is not actually dividing them into preventing depression and or preventing mania, but it's actually combined. So any new episode, there seems to be effective, at least to a similar degree as the classical mood stabilizers, which you see here, probably even slightly better, at least some of them. The problem really is with these atypical antipsychotics, what works often has side effects. And especially when it comes to the long-term treatment, what we fear most and what patients fear most are actually weight gain and, as a consequence, metabolic disturbances. So we know that a lot of them, as the older generation of the second generation antipsychotics, so olanzapine, quetiapine, risperidone, they actually are associated with quite massive weight gain, especially when it comes to long-term treatment. This actually shows short-term studies from 3 weeks up to 6 weeks, where mood stabilizer monotherapy plus placebo was compared to mood stabilizer plus a specific atypical antipsychotics. And you look at the mean weight gain over this pretty short periods, which you see here, 3 to 6 weeks. You see always a clear signal, also with significance, showing that the atypical antipsychotics do cause weight gain, or at least most of them. This actually might be better with the newer generation like lurasidone and cariprazine, which are more weight neutral, more similar actually to aripiprazole, which you see here. So coming to the conclusion of my talk and still having hopefully some time for discussion, classical mood stabilizers might be insufficient in treating acute bipolar depression. We know that lamotrigine works probably in preventing, but the acute data are at least doubtful. Lithium is actually or was not better than placebo in a randomized controlled trial in acute treatment of bipolar depression. The evidence for valproate is also pretty small, with 4 very small studies suggesting efficacy of valproate. So they might be not really very sufficient in treating acute depression. So we need probably other treatments, and adding antidepressants is definitely an option, which should be at least considered in severe bipolar depression. So what we know, and what I hope I could show you, is there is a good signal for their efficacy. And at least the modern ones like SSRI seems to be not really associated with, at least not a massively increased risk of switching, and seems to be safe in bipolar 2 and combined with mood stabilizers or antimanic agents also in bipolar 1. If you talk about the atypical antipsychotics, we have now good data for quetiapine, lurasidone, cariprazine, lumateperone, olanzapine, fluoxetine combination, and also to a lesser degree olanzapine alone, that they actually are effective in treating acute bipolar depression and also effective in preventing new episodes of either polarity. However, especially the older ones may have still a problem with the tolerability and safety when it comes to weight gain and to metabolic symptoms. Neither antidepressants or atypical antipsychotics, however, are probably ideal mood stabilizers. They all have their downsides, either side effects, either efficacy, either probably inducing in a subgroup like rapid cycling, manic episodes. So it's still actually on the agenda that we have to look into every individual patient and see what medication might suit him best and what is actually personal risk factors which should actually prevent us from using one or the other medication, and what are factors which actually would lead our treatment and use a specific medication. Now, this is the end of my talk. I just go back to, now I don't know whether you see also the automatic shut off in 3 minutes, 31 seconds on the screen. I have to switch off quickly my screen to get that off and switch it back on. Because otherwise my screen will be black in a few seconds. So, okay, now I'm back.
Thank you very much, dear Prof. Heinz Grunze, for your detailed review on the topic about antidepressants and antipsychotics and their role as a mood stabilizer effect. And we would like to ask you a question from Jibril Handele. He asks how we choose medication.
May I say a few words, Daria, before?
Yes, and the commentaries for the from dear Prof. Konstantinos Fontolakis. Okay. Yes.
Heinz showed the large problem in the treatment of bipolar disorder, because our problems are mainly not coming from mania, but mainly from those states related to depression, like mixed states, dysphoric mania, or agitated depression, or whatever. And the major problem is, of course, whether the major question is the problem where we will prescribe antidepressants and what kind. I would stress two papers. One, Heinz, one you mentioned, the Vasquez paper, suggesting that antidepressants are more efficacious in bipolar depression in comparison to unipolar depression, which is in sharp contrast to what we generally believe and teach, that antidepressants may not work at all in bipolar depression, but they have a strong effect on unipolar. Now, the Vasquez paper completely reverses that. And it's a strong finding. And the second paper I always like to mention is the Vieta study of venlafaxine versus paroxetine, where venlafaxine and paroxetine did not differ from each other. But this was because of the intent to treat method, because the dropouts in the venlafaxine arm were because of switching to mania, but they had a lot of responses, while in the paroxetine group, the dropouts were mainly because of lack of efficacy. The end result was more or less the same, but there was a qualitative difference. I would like you to make a comment on these two papers.
Yeah. Well, actually, the Vieta paper from 2002 was actually just one of the first who also just showed that venlafaxine is different when it comes to switching from the SSRIs. Also saying paroxetine is a pretty dirty SSRI, so a lot of other stuff also playing a role with it. And probably, as we know from other studies, not as efficacious as, for example, escitalopram or sertraline. So yeah, actually that's fully in line with also data from the Stanley Foundation. So as soon as you have some, or if you use an SNRI, you might actually have more efficacy, but you may have a higher risk. Also, the efficacy was not different really in the Stanley study. Unfortunately, we don't have other data, for example, for duloxetine, which might actually either support or contradict this finding. That would be good if you had actually more studies in this area. The other thing, the Vasquez paper, as you already mentioned, yeah, it's interesting, and it's contrary to what people tended to believe. But I would basically say the drug doesn't care whether your depression is bipolar or unipolar. It just treats the symptoms. And on a symptomatic level, I mean, there are quite a lot of similarities, and these similarities are basically treated by antidepressants quite efficaciously. I mean, antidepressants are also, strictly speaking, they are not just working on F31, 32, 33 diagnosis. They also work in anxiety. So, actually, the drug or the group of the drug really doesn't care about the ICD or DSM-4 classification which we give. They just work basically on a symptom. And I think this is an important thing. So we shouldn't be too dogmatic and saying only bipolar, because we label something bipolar depression. This basically is then clear that only mood stabilizers or atypicals can work and not antidepressant. And on the other hand, there's also some evidence that atypical antipsychotics, which we associate with bipolar depression, have also effects in other instances like unipolar major depressive disorder, at least as an augmentation treatment, or anxiety disorders. And with the Vasquez, the other thing you have to say, I mean, it's a bit difficult to compare, because there are 10 times as many trials in this analysis in unipolar depression than in bipolar, which makes this methodologically a little bit difficult really to compare.
And most bipolar trials are add-on or combination trials.
Yeah, where you basically have to subtract the contribution of the mood stabilizer.
It's methodologically not sound. Yeah.
Well, the thing is because we really don't know whether if it's a combination, whether they have additive effects, or whether the antidepressant multiplies the effect of the mood stabilizer, or vice versa. Is it just adding it, or is it adding it, especially what actually has been proposed with olanzapine fluoxetine combination treatment? That's not just the additional effect, but that somehow it multiplies the effect or makes the olanzapine stronger. by adding fluoxetine. So it's an area where we just have little evidence, but lots of beliefs. Daria, I think you got a question from someone in the audience. Yeah.
Yes, so we have a couple of questions, and I think we have a couple of minutes to answer these questions, to receive the answers. So one of the questions is from Dr. Jibril Handula. Is there any evidence-based data for bipolar depression for the elderly population, and how could you comment about this?
Yeah. Well, unfortunately, I mean, I showed you already in the meta-analysis is generally actually a lack of data. And those studies which were included in the meta-analysis, at least the older ones, had actually something like 12 to 30 participants. So even if you would try, even if that included patients above 65 and you would try to analyze them separately, you might come up with 1 or 2 patients in every single trial. Where we have some evidence for the treatment of bipolar disorder in the elderly is actually interesting for lamotrigine. They made a subgroup analysis for patients over 55, but not for acute treatment, but for long-term treatment. And lamotrigine was as effective in those over 55 in preventing new episodes as it was in the younger ones. So if you just have the assumption that there is no difference in antidepressant efficacies across age groups, but only in sensitivity to drug side effects and tolerability and metabolic issues, we would assume that the same, what we see actually with the younger population, but also hold true in the older population. And this, I think, is especially, and I think, Daria, this is a very, very important question, because what we also know is with the natural cause of bipolar disorder, mania might prevail in the younger years, but depression prevails in the old age population. So where we probably, and especially treatment resistant, chronic depression starts to prevail. So this is really also the age group where we just would need more rigorous testing of different treatment options, which unfortunately, which we don't have. What we have to keep in mind is really the issue of sensitivity to side effects and metabolic effects, and probably impaired kidney function, liver function in the older generation, which might lead to different dosing regimes as we have in the younger ones.
Thank you very much. Thank you very much, dear Prof. Heinz Grunze. And one more question about the CBT from Dr. Sukumar. How about the combination of drugs and CBT, or only drugs for this category of patients?
For which category? Sorry, I didn't get it.
Cognitive behavioral therapy in combination with
okay,
CBT, yes.
Yeah. Well, we would also always recommend, basically, whenever possible, just to combine any treatment of bipolar depression with a kind of psychotherapy. It doesn't always have to be CBT. It could be also interpersonal therapy. It could be family, something else. So an evidence-based treatment for depression and bipolar depression psychotherapy should always be also on the agenda, and probably should be the first kind of, or the first treatment, at least in the milder depressed patients, or who are not very tolerant to the drug medication. Yes, definitely. And there's also good evidence also for bipolar depression, for CBT especially. But I think the greater importance really of all these psychotherapies is the prevention of new episodes. So I think in most, at least in those bipolar depression patients, which I see on a regular basis in the hospital, just psychotherapy wouldn't really do the trick. So you need definitely a medication. You sometimes even need ECT. But when it comes basically then to continuation and long-term, at least at that stage, you should add a specific therapy, psychotherapy.
Thank you very much. Thank you very much for this recommendation. And one more question, the last question from the Dr. Anna Tsikishvili. She asks, what is your preferred combination in terms of efficacy, tolerance, safety, and affordability for bipolar 1 and 2 treatment, where depression is the leading disability? And how do you choose the next best drug combination when the initial combination doesn't work well for the patient?
So we just start already talking about combination, not monotherapy. Well, the best evidence really rests with olanzapine fluoxetine. There's a combination in acute treatment, also for continuation. So if it's well tolerated without any major weight gain or major sedation, that would be probably a first choice treatment. If it's not tolerated, I would actually just go for combination of a mood stabilizer. I still have a strong preference for lithium, to be honest. Either with something of the newer atypicals like Residone, for example, or cariprazine, which don't have this metabolic side effects, or the combination of lithium and lamotrigine, because you also have good data from Spain and the Netherlands that this combination is actually quite preventive or quite good in prevention of new depressed and manic episodes where lithium alone didn't work. So that were probably my preferences. In bipolar 2 patients, I actually would rather think about combining a mood stabilizer with an SSRI, especially in those bipolar 2 patients where depression is really the leading episode.
Thank you very much, dear Prof. Heinz Grunze. There were questions which you already really answered about lithium, so from other colleagues. So thank you very much for your amazing talk, and people already asking to reread, to rewatch your presentation, as it's full of detail and they would like to.
Yeah, very welcome to do this.
Thank you very much. Thank you very much. And now we move to the next stage of the program. I would like to ask Associate Professor Elena Wróblewska to introduce our next prominent speaker. Thank you very much, Prof. Grunze, once again.
Thank you.
Thank you, Professor Grunze. Thank you, Daria. And now I am pleased to introduce our second speaker, Professor Driss Moussaoui, who will talk about psychological help in rural areas, very important topic. So Professor has reached a number of professional achievements in his life, and I would like to stress that he was founder and the chairman of the Ibn Rushd University Psychiatric Center in Casablanca. He also was director of the Casablanca WHO Collaborating Center in Mental Health. He was president of the Moroccan Society of Psychiatry and of the Arab Federation of Psychiatrists. He edited or co-edited a number of books and is an author of plenty of important articles. He founded with the with the World Psychiatric Association Pardon and Executive Committee, the Jean Delay Prize, and is the scientific director of the WPA series International Anthologies of Classic Psychiatric Texts. Driss Moussaoui is the past president of the World Association of Social Psychiatry and member of the French Academy of Medicine. So he is WPA honorary member and currently president of the International Federation of Psychotherapy. Thank you, Professor, that you are with us today, and you are warmly welcomed to share your knowledge with us. The floor is yours.
Great pleasure to be here. Thank you very much for the presentation and for your kind words. For those speaking Greek in the audience, my daughter said, tell them yes. She speaks fluent Greek, and I'm extremely happy that my dear friend, Professor Kostas Fontourakis, invites me to join this important series of lectures. I have been a number of times to Thessaloniki and I miss this beautiful city and the Aristotle University team. I'm extremely pleased also to have with us my dear friend, Professor Afzal Jawad. It's really a pleasure to talk about something completely different from what we heard, although it is very, very important to have this biopsychosocial approach to psychiatry, because they are all extremely important. And I'm going to try to upload my presentation. And while doing that, I just wanted to say that Professor Fontylakis and myself, we had a very, very dear friend who was Hago Pakiskal. You all know about him and bipolar disorders. And I remember in early 1980s, he used to say antidepressants and antipsychotic medications are poisons for bipolar disorders. The only treatment is lithium. And I'm extremely glad that this opinion changed, because I mean, in my 50 years experience as a psychiatrist, as a clinician, I have seen that mood stabilizers are not enough, and that obviously antidepressants, antipsychotic medications are necessary for a number of people. Thank you very much, Professor Heinz Grunze, for this excellent presentation. Now I'm going to talk about psychological help in rural areas. No conflict of interest for this presentation. Now, just wanted to say something that is extremely important. I mean, we all try to learn the best science in psychiatry to help people. But we forget that everywhere in the world, especially in poor countries, very few people in the community are diagnosed with mental disorders. And among those, very few are treated among those diagnosed in a good manner. And most, unfortunately, many of them are not all, I mean, diagnosed with the complexity that is usually the case in psychiatry, with the comorbidities and so on. If we look at the low and middle income countries, and we look at the DALYs, the burden of diseases, we see that WHO says that mental illness, all medical conditions included, comes second, just after injuries. And in injuries, you have, of course, suicides. So in fact, mental illnesses plus suicide come first. Every single medical condition included. Oh, this is something very important to keep in mind. It is not because we are in Congo or Brazzaville or in Myanmar, or that only infectious diseases and child mortality are the problems. And comorbidity between physical and mental disorders are very, very, very common. Second, we know that everywhere, and especially in low and middle income countries, we have an increase of suicidal attempts and suicides at large. And we know that major depression, schizophrenia, bipolar disorders, of course, are risk factors for suicide. know also for poor countries that the total cost of illness is increasing steadily. In 20 years, from 2010 to 2030, it's almost multiplied by 3, from $870 billion to $870 million, sorry, to $2 trillion in 2030. That is, I would say, tomorrow. This is something, unfortunately, we see in many different parts of the world because of non-treatment of mental disorders, especially psychotic people, people with psychosis, including bipolar disorders. And people are chained. People are discriminated. Their human rights are violated. And not long time ago, that was maybe 5 or 6 years ago, the Moroccan government had to close a place where about 700 people with mental disorders were chained. I have to say that the Prime Minister was not only a medical doctor, he was a psychiatrist and one of my students. So it's a political fight for that. When you see, for example, a place like the island of Bali, if you have been there, I mean, it's a beautiful place, very touristic. Billions of dollars, I mean, no, millions of dollars are going there from tourists. If you go inside the island, you see a lot of these patients not treated and chained. Hell inside paradise. Even rich countries have problems to treat all mental disorders, people with mental disorders. Half of people with schizophrenia in the United States of America, the richest country in the world, are not treated. Half of the persons with depression in France, with 14,000 psychiatrists, are not diagnosed and not treated at all. In poor countries, who have, for example, not only the diagnosis gap, but the treatment gap for epilepsy in a number of countries is higher than 99%. And people die of that. For psychotherapy, psychological help, it's even worse. I received today the final draft. I mean, it's not the draft, it's the final version of a working group on psychotherapy by the Academy of Medicine of France. Because they realized with the pandemic that not everybody, I mean, with a lot of people with depression, anxiety disorder, had no access whatsoever to any kind of help. So they created, in 5 small regions in France, they made a pilot project, general practitioners working with clinical psychologists for 10 sessions of psychotherapy for these people in need with mild depression or anxiety disorders. And the president of France, 3 days ago, talked about that, saying it's extremely important that we give help to those in need with psychotherapy because not everybody can have access to that. Treatment gap is worse in marginalized groups like jail inmates. How many people think of prisoners in jails saying that these human beings, whatever terrible things they did, are our brothers and sisters, and they need help from the psychological point of view as well. Homeless people, street children, LGBT in many different countries, and so on and so forth. I mean, in Afghanistan, not only they do not help LGBT, but they are looking for them to kill them. Talking about the Taliban. In poor countries and regions, of course, and many rich countries have remote regions or poor regions, suburban and rural populations. We should not forget that if we consider the about almost 8 billion people on this planet, about 40%, 45% of the total population of the world is rural. And for psychotherapy and psychological help, it's even. We should keep also in mind this. Whatever effort we do in the future, we will never, ever have enough medical doctors, psychiatrists, psychologists, clinical psychologists, and other mental health workers. Never. And when I have visited in the United States of America, places with 100, 120 people with the substance abuse problems. They were there to sleep, to eat, and that's it for 3 weeks. And then to the street. Nothing, not a single mental health worker there. Just one old user of substances was there to take care of these, to help as much as he could, these 100, 120 people. I have seen in New York, that was in 1989, not too long time ago, one big place with 1,000 beds for homeless. One bed near the other. That was a gymnasium and something like that. And that was 50 meters or 100 meters from the New York State Psychiatric Institute. At that time, $75 million budget, annual budget, and about 500 researchers and people working. For these 1,000 homeless people, there was not one resident helping these people. This is to say that it's a problem for the whole world, but we should keep it in mind. It's there, what to do. We should not forget that the oldest model in medicine are midwives and sorcerers. I mean, ladies who helped others to deliver, and some people who established a kind of medical care or health care for people who have a fracture, who have fever, whatever, and who have mental problem, prayers, with herbal medicines, and so on and so forth. In Pakistan, there was a paper published in 27 in the Lancet about community psychiatry. I would like to mention here the name of a dear friend who unfortunately also passed away. He was near Islamabad, and he did a fantastic job at the end of the 70s and the early 80s. And that was a beautiful work done in the rural areas with the community health workers and so on. In Cameroon, you have ladies called aunties, respected by the community, who could help others, I mean, especially women, who are in need of help, psychological help. In Brazil, there is community therapy as well. In many different parts of Brazil, a beautiful work done by a good friend of mine. And there are other places with what they call friendship benches. When somebody is in need of just somebody else to talk with, they go to this bench, they sit there, and they are helped one way or another. And this has been shown as being effective. Studies have been conducted showing that this low-tech coming from people who had some experience, but not too much training, still helpful. I have participated, I created, in fact, for the World Association of Social Psychiatry with Sanofi in France, a program called Fight Against Stigma, FAST program, in 2007, and it is still continuing to function. It worked, and it's still working in a number of countries, but it worked in about 23 different countries in the world to help train general practitioners and to help ministries of health to access more easily to psychotropic medications. And with International Federation for Psychotherapy that I have the honor to chair, I started in Morocco. I initiated in 2019 a program, a pilot project called Psychological Help in Rural Areas. This is to help women with perinatal depression, their families as well. Empowering ladies from the villages. I call them, I mean, they are all female. Psychological helpers, chosen in the village by the women themselves. It's a partnership between IFP, Ministry of Health, Bakura Education Foundation. I'm the vice president of this foundation, and we have, for the past 22 years, had hundreds of schools in rural areas. So it's, we work together, hand in hand. NGO helping hospitals for some money, and the WHO collaborating Center in Mental Health of Casablanca. First step, I visited 11 villages with 1, then 4 residents on sometimes very difficult roads, somewhat dangerous in many different parts of Morocco. We gathered about 350 women in schools of the villages, and a few men attended as well, briefly informed them about depression at large and postnatal depression in particular. We have conducted in my department, when I was chairman, I retired in 2013, 2 studies on pregnant women with a follow-up of 1, that was 1 group, 1 year, and 2 years 1 year before, 1 year after. And the two studies found about the same thing. 20% of pregnant women and after delivery having depressive episodes. Feedback from women, that was something interesting. Many attendees, and I'm talking about most of these women are illiterate, described publicly, many described publicly their depression, some of them having experienced suicidal ideation or behavior. Some of them didn't want to speak publicly, but asked to talk to the female residents who were with me. I was extremely impressed on how the description was accurate. The literacy of these women was really impressive. 20% of these ladies had in the past or at present a depression, 32 with perinatal depression, and 10% of them describing suicidal ideation. Of course, I mean, this is just, it's in 11 villages. It's a small group, relatively small. But it goes with a national epidemiological study we conducted in Morocco on a representative sample of the whole population in 2007. And we found about the same figures in the general population. Ladies who were chosen were very much trusted by the others. Out of the 4, we chose 4 villages out of the 11 on the short list, but one association of one village said, we don't want this project. And one village, they chose 2 women, and the husband of one woman said, no way that my wife goes to Casablanca for training. Forbidden. So we chose 2 villages, Shrahba and Walad Tamsaid, in the region of Sidi bin Noor. And when we go there, we leave here by 7 a.m. and we come back about 8 p.m. It's a long journey. Training of the 4 women with the supervisor from the Zakura Education Foundation. 2 out of 4 of these women were illiterate. And one, at the very end of the 2 days of training, described an extraordinary way of helping a lady with breast cancer. And she explained how she was receiving every day this woman with some mint tea, with some cookies, music, dancing, and this changed completely the way this lady was perceiving her life. We taught them how to identify depression, how to assess it, what are the consequences if not treated, what to say, what not to say, especially to the husband and the mother-in-law. Very important. The mother-in-law, extremely important traditionally in this country, and what to do to help the newborn in this situation. Logistic issues, all expenses taken care of. Psychological helpers were given a telephone device, can call 24 hours over 7 days, and visit to the 2 villages every month or every 2 months. First consultation, it was an interesting thing. It was on the 24th of September 2019. We saw a tent near the school. About 60 women and some men were waiting, and we were invaded by a tsunami of requests of all kinds. All medical problems came. Eye illness, Hirschsprung illness in a 10-year old child, cardiac disease, diabetes, but mostly psychotic disorders. 43 patients in the 2 villages were seen in consultation, and some were unhappy because night was coming and we could not see everybody. Second consultation, we saw 71 patients. A present was given to the villagers. They were very happy with that. Blood pressure monitor and a thermometer. An interesting thing from the second consultation, in one village, they were extremely happy with the outcome. Smiling, welcoming. They went to the Ministry of Health to take their medication. And they were happy with that. And the other group, the other village, wasn't happy because they wanted the medication given to them on the spot. The interesting thing, what we learned there from the very beginning, is that 2 villages in the same region, the rural areas, nothing could distinguish one from the other. 37 kilometers one from the other. Had a completely, everything else the same, had a complete different outcome. The funny thing is that where it went well, the association of the village was so-so, not very enthusiastic about the experience, about the experiment. And the village where it didn't go well, the association was happy with the work we were doing. The pandemic stopped everything, beginning of 2020. No travel allowed. We resumed consultations in March 2021. We did a refreshing course for the 4 ladies, and then other consultations were done. But in May 21, we stopped the village that was unhappy because we saw less and less patients. And we chose another one in June to replace it. The whole project is supposed to have a duration of 2 years. This is the way we are working in these schools. So far, we saw 306 patients, mostly women. It was impossible during pandemic to conduct virtual consultations for technical reasons. No internet available. And the complaints from the anthropological point of view were interesting in women. It was repetitive. Too much pressure from the husband, too much pressure from the mother-in-law, too many children, not enough time for themselves, no confidence in a corrupt health system, in the nearest hospital, poverty, and so on and so forth. And we were amazed with this huge difference between the 2 villages. There are subcultures. I mean, if we talk, for example, about Moroccan culture, that's one thing. If we talk about rural Moroccan culture, that's another thing. And the interesting thing is that the way we were received from one region to another was different. So there is a subculture there from one place to another. Another interesting thing, not a single word about traditional healing. That was a very interesting. No, nobody spoke about it at all. And more of the severe cases were still hidden, talking about severe schizophrenia, bipolar disorders, and so on and so forth. And men were reluctant because the thinking was, what's this? Project done for women only? And us, we are the important people. But some of them came to us with physical complaints and problems. And probably at the end of the 2 years, then we will have a much interesting relationship. To conclude, to say this is just the beginning, we have conducted about, 7 months so far, 8 months maximum. We will continue next. I think it will be next Monday, not this Monday, the Monday afterwards, next week. We will go again there and continue our work with the new village and the old one. It's an interesting adventure with cultural issues, and we expect, we hope that we will change attitudes in 2 years from now. And the interesting thing is that I have spoken about this program in a number of times, and at least in 2 countries, the Ministry of Health of Madagascar and Armenia, the people responsible, the focal points in these ministries in mental health showed interest in having this kind of program for their countries. So if we have success in these 2 villages, we will try with the Ministry of Health to expand in other regions in Morocco. And if other countries are interested, of course, we will help with the expansion of this program in these countries as well. This is to thank a number of people who helped for training and for consultations and so on and so forth. Thank you very much for listening.
Thank you, dear Professor, for this really outstanding presentation. It raised so many thoughts, and this topic is really important. And I would like to ask Professor Afzal Javed to give your comment on this lecture. It would be very nice to hear some words from you.
Well, thank you very much, Professor Driss Moussaoui. As always, you have been very clear, very precise, and just touching the most important aspect. And I think you very comprehensively covered the topic and raised some important questions, especially in terms of our future perspectives in service delivery. I'm sure that these thoughts will go a long way in shaping and reshaping our concepts about this particular topic. So thank you very much, sir. Thank you very much for your kind acceptance to be a speaker in this webinar.
Pleasure.
Thank you, Professor Afzal Javed. Professor Konstantinos Fontoullakis, we also would like to hear some of your comments.
Thank you, Yelena. Dear Driss, that was an excellent talk, and thank you for your kind words also. It's a great pleasure to have you here with us, and we hope to have you here again in Thessaloniki in the next few months. Let's hope. I would like to say a few words. I am often asked, taking my orientation as a psychopharmacologist rather than a social psychiatrist, what's the future of psychiatry and mental health? And I always say that we should take as granted that in the next few decades, there will be some major breakthrough in terms of pharmacological treatment, some great neuroscientific breakthrough. The issue is not whether this breakthrough would be radical and very efficacious. As we saw with this pandemic, the real question is whether people will embrace this, because you might have the perfect drug, but if people are not willing to take it, if we don't have the mechanisms to have the proper diagnosis, if cases are hidden because of stigma or because of whatever social isolation or prejudice, then no matter how good treatment options you have, the result will be the same. So one of the major challenges our field will face in the near future is to be able to summon an alliance of all social forces and currents in order to improve dissemination of knowledge, access to healthcare, and to reduce what you said, what you call the gap. So this might be a more important issue when we talk about public health, mental health, and we are talking about billions of people. If we were able right now to provide the state of the art to 8 billion people, that would be much more important than to have a new agent that has 50% better efficacy. So public health goes through social psychiatry, and it's very important what you discussed.
Thank you, Professor Fontoullakis. We also have a couple questions from the audience. So Dr. Jibril Khanduleh, sorry if I pronounce your name not in the correct way, doctor asks, in Moroccan culture, what are the explanatory model for severe mental health disorder?
Well, before, it was all kinds of things that existed in Europe at the end of the 19th century and at the beginning of the 20th century. That was the evil eye, sorcery, all kinds of interpretation of the traditional kind, and progressively things, or religious. You know, for example, for depression, at the end of the 19th century, most of depressions in France were of the kind of persecutory, paranoid ideas that somebody would like to hurt them. At the beginning of the 20th century, it was mostly guilt. I have done something bad with God and I'm paying for that. And progressively, it came down to a better literacy of depression. And people more and more talk about serotonin in the brain in Morocco. And just to tell you that when I came back from Paris in 1979, the word depression in Arabic here in Morocco, iktiab, didn't exist at all. And I started going from one radio station to another, from one TV to, and talking about depression, antidepressants, this, that, and the literacy. I was amazed to see that in rural areas, people knew what was depression. So progressively, you know, the cultural differences that existed before are waning, are diminishing, and mainstream is becoming the mainstream everywhere, progressively.
Thank you, Professor. Dr. Elisaveta Iseklian is asking how to become a participant of your community and provide psychiatric help in rural areas as a physician. So what is needed for that?
Unfortunately, I do not have enough money to invite her to join us. But if she can afford to pay for a plane ticket and to come, I would be delighted. I mean, we work in Arabic, in Moroccan Arabic, and if we have to translate every single sentence, that would be something difficult. That would slow down the process very clearly. But whenever she wishes, what I can do is, Kostas, please, I agree to give my mobile phone number and email address to this lady, and she can call, WhatsApp call, whatever, whenever she wishes. And I would be delighted to respond to all questions she has and to give her more insight on what we are doing now in this pilot project.
That's really great. Professor, I also have one question from me. As you are very wise and experienced and you have huge knowledge in psychiatry, my question is, what is the prevalence of severe mental illness among homeless people?
First, wisdom is something extremely difficult to achieve and to reach. My mother used to say, the smartest of all people is visited by stupidity 7 times a day. And from time to time, I say, this is one of the 7. So wisdom is a long path, and we have to be very careful with that. Second, your question, sorry, I forgot the question you were asking. Sorry for that.
Yes, mental disorders are prevalent among homeless people. Yes.
Thank you very much. When I came back from Paris in 1979, the first study I conducted in my department, and at that time we had 4 cities and 5 million inhabitants, and we were only 3 or 4 people. I was the only psychiatrist for the public and the academic sector, and I had 2 or 3 residents with me, and I took one of them, and I asked him to do a work on homeless, because the governor of Casablanca gathered all the homeless they found in one place. And for weeks, this guy, Brahim Ben Brahim, saw every single one of the 1,000, I think it was 1,100 homeless or something like that. And the prevalence of schizophrenia in them was 42%. Huge, huge. And this is something done in Casablanca. And of course, one of the ways to help, you have 2 things. First, we need to afford medications for those who cannot buy them, and to convince the patient to take his medications. And we need to help the family, to help the patient in order to be compliant with this treatment. Otherwise, if they stop their medication, they relapse, they destroy everything in the house. And first time, second time, family is fed up with that and say, go to the street. We don't want to see you anymore. That's what happens. We need to help the patient and to help the helpers to help the patient. With associations of families, We have a number of them. We have one association of users, and this is all small yet as compared to the needs of the community, but still.
Yeah,
it's the beginning.
Thank you, Professor. Actually, colleagues from the audience, they really want to have references from presentations. I don't know whether these presentations will be available, but I want to say that both talks are recorded, and it will be possible to watch them. So, and to get the references, and maybe if somebody is particularly interested in some concrete reference, maybe it is useful to write directly to you, Professor.
Exactly.
So, colleagues. Okay, so we don't, sorry, I will check whether we have any other questions. Yes, one question, one more question. I would like to know your thoughts about the changes, the new paradigm on ICD-11 regarding personality disorders. Do you agree, or do you feel is the wrong way to assess personality disorders? This question comes from Dr. Miguel Antonio Salas. So personality disorders and ICD-11.
Well, this is, it's a little bit outside the presentation of today. Personality disorders, very important issue and very controversial. We know that. I mean, I know that ICD follows to some extent what happens in DSM. We know that. And in DSM, it has been a huge fight till the end for the problem of personality disorders. And many, even some extreme scenarios saying we are just going to shut down the whole thing. So, I mean, it's very difficult to respond simply to a very, very complex question and issue.
May I add something?
Yeah.
Next month, we will have with us Daryl Regier,
yeah,
who was one of the
absolutely.
pillars of DSM through the ages, through decades. So save your questions of this kind for Daryl.
Daryl is a great. I like him very, very much, and he has done that with the NIMH, with the APA, all the way along. So he will give you all details. But I know that, I mean, few days before giving the final version of DSM-5, they were still fighting on that.
Kostas, I think we don't have any questions anymore at the moment.
Then we can conclude this Meet the Expert, and we will renew our appointment for next month. Next month will be with Daryl Regier and Roger McIntyre. Driss, if you are available, I would be honored that you join me as a co-chair of this Meet the Expert for Daryl and Roger.
The honor is mine and the pleasure is mine, truly. Absolutely, I would be delighted.
So thank you everybody for joining us until next month. Afzal, take care.
Thank you.